Usually when we talk about a surgical diagnosis, there's this expectation of almost engineering-like precision. Like you break your femur, the x-ray shows a jagged white line, and the orthopedic surgeon just points to the screen.
Right. They just say, there's the problem, and here's the hardware we use to fix it. It's a very binary way of looking at medicine.
Exactly. It's broken or not broken. Resectable or unresectable.
Yeah, and I mean, as surgeons, we inherently prefer pathology that just respects anatomical boundaries. It makes things manageable.
But then you step into the world of advanced pelvic oncology, and, well, those clean boundaries completely vanish. I mean, we're looking at a surgical and diagnostic landscape that is incredibly murky.
Oh, absolutely. The tumors we're talking about, locally advanced primary tumors or massive pelvic recurrences, they do not respect the fascial planes you learn about in medical school. They just invade whatever's in front of them.
And that's what makes this deep dive so compelling for you guys listening. We're exploring the definitive 2022 medical text, Surgical Management of Advanced Pelvic Cancer. It's edited by Michael E. Kelly and Desmond C. Winter.
It's an incredible resource.
It really is. We're tracing the entire clinical pathway of pelvic exenteration.
Yeah.
So taking a patient from what was historically considered an automatic death sentence to the very edge of what is, surgically survivable and eventually back to their daily life.
The historical context is crucial here, I think. For decades, if a colorectal or gynecological tumor invaded the pelvic sidewall or the sacrum, the surgeon simply closed the patient back up. We just called it unresectable.
Sorry, we can't do anything.
Exactly. But today, we are actively converting the incurable into the curable. But doing so requires an approach that completely upends traditional surgical compartmentalization.
So let's start with how you even prepare a patient for a physiological trauma of that magnitude. Because before a scalpel ever touches the skin, the sources emphasize that the success of the operation is heavily dictated by preoperative optimization.
Right. Prehabilitation.
Yeah, prehabilitation. You don't just schedule this surgery for the next morning.
Oh, definitely not. You're about to subject the patient to an operation that could last anywhere from 10 to 14 hours. It induces massive metabolic stress.
Wow, 14 hours.
Yeah, it's a marathon. And to survive that, a patient's general physical condition, their baseline reserve, is the single most important determinant of postoperative complications.
So how do you measure that? Just standard blood tests?
Well, the clinical protocol mandates rigorous cardiopulmonary exercise testing, or CPAT. We need objective data on whether their heart and lungs can withstand the massive fluid shifts and the systemic inflammatory response that exenteration triggers.
The nutritional protocol stood out to me as well when I was reading this. The text mandates a minimum of 7 days of preoperative nutritional support, aiming for at least 10 kilocalories per kilogram per day. I imagine the tumor itself is, already draining the patient's resources.
Yeah, exactly. Tumor biology fundamentally alters a patient's metabolic state. It prioritizes the malignancy's growth over the host's tissue maintenance.
So they're in a state of cachexia.
Precisely. And if you take a malnourished patient into a pelvic exenteration, their tissues simply will not heal. The anastomosis will fail. You have to actively reverse that catabolic state before surgery.
Along with correcting any anemia, right? Because I assume there's going to be substantial blood loss.
Oh, you must assume massive intraoperative blood loss, so correcting anemia is non-negotiable.
And while the patient is going through all this prehabilitation, the surgical team is mapping the terrain. The sources point to the MRI as the absolute gold standard for this.
It's the ultimate roadmap.
Right, because it's not just about confirming there's a tumor. It's about defining the margins in 3 dimensions to see which pelvic compartments, anterior, posterior, or lateral, are compromised.
And that MRI dictates the entire surgical strategy. It tells us if the tumor is threatening the major neurovascular bundles or the bone. And crucially, it dictates who needs to be in the operating room.
Because a standard multidisciplinary team in MDT just isn't enough for this.
No, not at all. Because the tumor ignores anatomical lanes, the surgical team has to cross them. You need what we call a super specialized MDT.
So who's on that team?
You're talking colorectal, urology, gynecology, plastic reconstruction, and often vascular and orthopedic surgeons all operating in tandem.
I do have a question about relying so heavily on that imaging, though, because the vast majority of these patients are dealing with recurrent cancers, right? Meaning they've already had extensive neoadjuvant chemoradiotherapy or previous surgeries.
Yes, exactly.
And the sources say that radiation turns the pelvic tissue incredibly dense and fibrotic. So when a surgeon is actually looking at that MRI or even feeling the tissue in the OR, how do they distinguish between a dense radiation scar and an active microscopic tumor?
The reality is, they often cannot.
Wait, really? They can't tell the difference?
No, neither the MRI nor the surgeon's tactile feedback intraoperatively can reliably differentiate between radiation-induced fibrosis and viable tumor cells. They both present as dense, fixed, unyielding tissue.
So if you can't tell the difference by touch or sight, how do you know what to cut?
Well, the core oncological principle in pelvic exenteration is that you must widen the surgical resection into healthy virgin tissue. You do not try to peel the tumor off a suspected fibrotic organ.
So you just take the whole organ.
Exactly. If the mass is fixed to the bladder, you take the bladder end block with the tumor. The overarching mandate, and really the single factor that dictates long-term survival, is achieving an R0 resection.
Right, R0 meaning microscopically clear margins. The sources specify an absolute minimum of a 1 millimeter buffer of healthy tissue around the entire resected specimen.
A 1 millimeter margin is the threshold between a curative operation and a futile one. If you leave even microscopic disease behind an R1 resection or macroscopic tumor in R2 resection, the cancer will almost certainly recur.
And if it recurs after an exenteration, there are no surgical options left.
None. The mandate is R0 or do not proceed.
So once the MRI defines that R0 perimeter, how does the surgical team physically navigate the anatomy? You aren't just carving out a mass, you are removing entire organ systems depending on where that tumor is anchored.
Yeah, we categorize the approach based on which compartments are cleared. Let's look at anterior pelvic exenteration first.
Okay, so that's pushing forward.
Right. If a rectal or cervical tumor pushes anteriorly, you have to sacrifice the urinary and anterior reproductive systems. In women, that means removing the bladder, lower ureters, uterus, ovaries, and the anterior wall of the vagina.
And in men.
It's a cystoprostatectomy, so removing the bladder, prostate, and seminal vesicles. But in an anterior exenteration, the rectum is typically spared.
Okay, so what if the tumor dynamics are reversed? Say a recurrence manifests in the presacral space and pulls everything backward.
Then we move to a posterior pelvic exenteration. You're removing the rectum, uterus, ovaries, and the posterior vaginal wall, but sparing the bladder.
I noticed the data shows this is rarely needed for primary tumors, though.
Yeah, occurring in less than 5% of cases. But it is highly relevant for recurrent malignancies that tether to the sacrum.
But the most profound anatomical alteration has to be the total pelvic exenteration, or TPE. This is the end block removal of everything rectum, bladder, and all internal reproductive organs.
You are essentially emptying the entire pelvic bowl.
It is just a staggering physiological alteration. To safely achieve a TPE, the physical setup of the operating room and the ergonomics must be critical.
Oh, absolutely. The patient is typically placed in a modified Lloyd-Davies position.
That's the steep lithotomy Trendelenburg stance, right? Legs up, head tilted down.
Precisely. This specific positioning allows two surgical teams to work simultaneously. You have one operating from the abdomen, working downwards, and another operating from the perineum, working upwards.
And they just meet in the middle?
They meet in the middle to mobilize the massive specimen. And because they're working deep in this narrow, funnel-shaped, highly vascular space, they rely heavily on advanced energy devices.
The sources mention ultrasonic scalpels and advanced bipolar devices. You're not just tying off blood vessels with silk sutures down there.
No, suturing deep in the pelvis is incredibly inefficient and dangerous. Ultrasonic devices allow the surgeon to simultaneously seal and transect vessels up to 7 millimeters in diameter in a fraction of a second.
Oh, wow. 7 millimeters is huge.
It is, and more importantly, these devices minimize thermal spread. When you're operating mere millimeters away from the delicate autonomic nerve plexuses that control lower extremity function, you cannot afford collateral heat damage.
That makes total sense. Now, that deep pelvic dissection makes sense when the tumor stays within the visceral organs. But earlier, you mentioned that historically, tumors invading the pelvic sidewall or the bone were deemed unresectable.
Right.
What happens today when the tumor doesn't just stick to the organs, but invades the actual structural cage of the pelvis, the bones, the major blood vessels, the somatic nerves?
Well, this is really the frontier of modern pelvic oncology. When a tumor breaks out of the visceral planes and invades the musculoskeletal or vascular boundaries, we transition into extended resections.
This is where the orthopedic and vascular guys come in.
Exactly. They have to integrate seamlessly with the colorectal and gynecological surgeons. Let's take sacral invasion as an example. If the tumor is fixed to the sacrum, peeling it off guarantees an R1 or R2 resection.
So you have to perform a sacrectomy. Removing a portion of the spine itself?
Yes.
That seems like an immense logistical challenge mid-surgery.
Yeah.
How do you resect the spine from an abdominal incision?
Well, if the invasion is relatively low, say, below the S3 sacral nerve root, the orthopedic surgeon can often transect the bone from the standard abdominal lithotomy position.
Okay, but what if it's higher?
If it involves the S1 or S2 levels, the patient's abdomen is temporarily closed and they are physically flipped over into a prone position. The orthopedic team then resects the sacrum from the back, dropping the entire en bloc specimen down through the pelvis.
That is wild. And the sources detail similar extremes for lateral pelvic sidewall involvement. They outline procedures with acronyms like LER, laterally extended endopelvic resection, and ELC.
Yes, these are techniques specifically designed to achieve that R0 margin even when the massive external iliac vessels or the sciatic nerve are encased in tumor.
The mechanism behind LER is fascinating. Instead of attempting to separate the tumor from the lateral wall, the surgeon just takes the entire lateral compartment.
Right. They will ligate the internal iliac vessels at their origin and remove the pelvic sidewall musculature en bloc with the tumor. But stepping into that lateral space introduces severe neurological trade-offs.
You're talking about the obturator nerve. Okay?
Exactly. The obturator nerve runs directly along the lateral wall. If it is encased, it must be sacrificed.
And the clinical consequence of that?
The patient will wake up with profound weakness in the adductor muscles of their leg. They'll really struggle to pull their leg inward. It is a calculated neurological sacrifice to ensure oncological clearance.
It's a stark trade-off.
That.
But as complex as the neurology is, the most immediate intraoperative threat the sources highlight is major hemorrhage. I mean, the pelvis is a highly vascular hub.
It's not just the major iliac arteries either. It's the presacral venous plexus.
Right, the presacral venous plexus.
Yeah.
It's described as this fragile, web-like network of valveless veins plastered directly against the periosteum, the covering of the sacrum.
And if a surgeon inadvertently tears this plexus while mobilizing the rectum, the bleeding is torrential.
Just massive hemorrhage.
And here is the mechanical nightmare. Because these veins lack valves and are tethered to the bone, they retract into the bone itself when torn.
Oh, no. So you can't clamp them.
You cannot simply clamp them, and if you try to suture them, the needle just tears the bone hole wider, worsening the hemorrhage.
That sounds like a catastrophic cascade. If you can't clamp and you can't suture, what is the crisis management protocol? How do you prevent the patient from exsanguinating right there on the table?
The protocol is immediate, aggressive damage control surgery. If the hemorrhage is uncontrollable, you utilize pelvic packing.
Just physically packing it.
Yes. The surgical team firmly packs the entire pelvic cavity with surgical swabs, applying direct, sustained mechanical pressure against the sacrum. And this is the hardest decision for a surgeon to make, they temporarily abandon the procedure.
Wait, they just stop.
They close the abdomen over the packs and send the patient directly to the intensive care unit.
You literally pause the surgery midway through. You pack the wound, keep the patient sedated in the ICU, and just wait.
You have to. Pushing through severe hemodynamic instability is universally fatal. Massive blood loss triggers the lethal triad: hypothermia, severe metabolic acidosis, and coagulopathy.
Coagulopathy, meaning the patient's blood physically loses the ability to clot.
Exactly. Recognizing when to stop, pack, and let the intensivist team correct the patient's metabolic failure over 24 to 48 hours is what saves the patient's life. You return to the operating room only when the physiology has stabilized enough to withstand the completion of the resection.
Man. Let's assume the destructive phase is finally complete. The tumor is out, the margins are microscopically clear, the bleeding is controlled. The surgical team is now staring down into what the text explicitly refers to as the empty pelvis.
It's a massive anatomical void.
Because you've removed the bladder, the rectum, the reproductive organs.
And that void is a profound liability. Crucially, the tissue surrounding this newly empty cavity has almost always been heavily irradiated from prior cancer treatments.
So it's not healthy tissue to begin with.
No. Radiation causes microvascular damage. The tissue is fibrotic, hypoxic, and fundamentally hostile to wound healing. If you simply close the perineal skin over that void, the small intestine will inevitably descend into that rigid, empty space.
Which leads to complications.
Severe complications. The bowel can become obstructed, it can adhere to the raw pelvic floor and form fistulas, or the patient can develop a massive perineal herniation. You must actively fill that dead space with healthy, highly vascularized tissue.
And this is where the plastic and reconstructive surgeons take the lead. The primary technique detailed in the text is the VRAM flap, the vertical rectus abdominis myocutaneous flap.
The VRAM flap is a brilliant anatomical solution to the empty pelvis syndrome. The plastic surgeon harvests the rectus abdominis muscle from the abdomen along with its overlying skin paddle.
The six-pack muscle, basically.
Exactly. And critically, they keep its primary blood supply, the inferior epigastric artery, completely intact. They then swing this entire bulky pedicle flap down into the pelvis.
So it serves two distinct anatomical purposes then. It does. First, the skin paddle is used to reconstruct the massive defect left in the perineum. Second, the thick muscle belly fills the dead space, acting as a physical hammock to keep the small bowel up in the abdomen where it belongs.
That's incredibly clever. And because the flap brings its own rich, not irradiated blood supply, it radically improves the healing environment of the radiated pelvis.
While the plastic surgeons are doing that, the urologists and colorectal surgeons are busy reconstructing the patient's urinary and digestive tracts because stomas are almost universally required here.
Yes, almost always.
The standard for urinary diversion mentioned is the ileal conduit, where the ureters are implanted into a short segment of isolated small bowel that constantly empties urine into an external stoma bag.
Now, in highly selected, usually younger patients with less prior radiation, continent reconstructions like an Indiana pouch might be considered.
Which avoids an external bag.
Right. But regardless of the specific diversion, the anatomical rearrangement is massive.
Which brings us to the morbidity. We have to be honest about the toll this takes on a human body. The text notes that in high-volume expert centers, the in-hospital mortality rate is impressively low, usually between 1% and 3%.
That's a huge achievement.
But the complication rates, the morbidity, is staggeringly high. We are talking about 34 to 80% of patients experiencing a major complication.
We're talking sepsis, urinary leaks, deep pelvic abscesses, stomal necrosis. There's even a phenomenon known as well leg compartment syndrome.
What is that?
It's where simply being in that steep lithotomy position for 12 hours decreases arterial perfusion to the lower leg so severely that the calf muscles sustain ischemic damage.
Wow. As a clinician, analyzing an operation with an 80% morbidity rate forces a difficult ethical and clinical question. Are we genuinely serving the patient's best interests if we are almost guaranteeing them a severe complication, an extended ICU stay, and permanent anatomical alterations?
It is the ultimate clinical dilemma, but you cannot evaluate the morbidity of pelvic exenteration in a vacuum. You must weigh it against the trajectory of the untreated disease.
Right, because doing nothing isn't benign.
Far from it. Advanced unresectable pelvic cancer does not offer a peaceful decline. The tumor aggressively invades the somatic nerve roots, causing intractable, agonizing neuropathic pain that high-dose opioids barely touch.
That sounds horrific.
It is. It erodes through the bladder and bowel walls, creating massive internal fistulas where stool continuously passes through the vagina or urine pours into the rectum. The resulting chronic sepsis, massive bleeding, and profound loss of dignity are horrific. The surgery is undeniably brutal, yes, but the untreated disease process is vastly worse.
Which naturally bridges into the long-term data on outcomes and quality of life, because surviving the operation and healing the incisions is only the first hurdle. The text spends significant time analyzing the quality of life or QOL trajectories over the months and years following an exenteration.
And the trajectory is remarkably consistent across the literature. As you would predict, patients experience a steep, severe decline in their physical function and overall quality of life during the first 3 to 6 months post-operatively.
That makes sense. They are exhausted, navigating complex new stomas, and mourning the loss of major organ systems.
But the data also shows a profound recovery curve. The majority of patients who achieve that critical R0 margin actually return to their baseline preoperative quality of life scores by roughly 6 to 9 months.
It's a profound testament to human adaptability. But that recovery is heavily influenced by specific predictors, right? Yeah. The sources identify that patients requiring multiple ostomies, females dealing with sweeping psychosexual changes from vaginectomy, and patients who underwent major bony resections naturally struggle more with long-term adaptation.
Uncontrolled preoperative pain is also a really strong predictor of a difficult psychological recovery.
And oncologically, the most devastating predictor of poor quality of life is an R2 margin. If macroscopic tumor is left behind, the agonizing symptoms of the cancer return almost immediately, compounding all the surgical trauma the patient just endured.
It's the worst possible outcome.
Yet despite the mandate for an R0 resection, the text does outline a highly specific scenario where exenteration is performed without curative intent. Palliative pelvic exenteration, or PPES.
Palliative exenteration seems entirely counterintuitive given the 80% morbidity we just discussed. Why put a patient through a 14-hour surgery if you know you cannot cure them?
Right.
The answer goes back to the horrors of the untreated disease. PPEs is strictly reserved for relieving the most severe refractory symptoms, malodorous fungating tumors, debilitating fistulas, or intractable nerve pain.
But the selection criteria for that are incredibly strict, aren't they?
Absolutely. It is only offered to relatively fit patients who have chemoresponsive distant metastases.
Meaning they have some life expectancy left.
Yes, but who absolutely cannot be palliated with less invasive options like ureteral stents or nerve blocks. It is a massive intervention for symptom control, and the shared decision-making process with the patient must be completely transparent regarding the risks.
It really emphasizes how multidisciplinary care extends far beyond the physical operating room. I mean, the mechanical excision of the tumor relies on the surgeons, the energy devices, the VRAM flaps.
Right.
But restoring a patient's functional and psychological baseline relies on the stoma nurses, the physical therapists, the pain specialists, and the psychologists working with the patient for months, sometimes years, after discharge.
The surgical technique provides the opportunity for survival, but the allied health team ensures that survival is actually worth living.
Very well said. To bring all of this together for the medical learners tracking this pathway, we've navigated the vital necessity of preoperative CPIT testing and nutritional loading. We've seen how the MRI dictates the RR surgical planes, forcing surgeons to completely dismantle the anterior or posterior compartments or perform total end-block resections.
It's an incredible amount of information to synthesize.
And we examined the biomechanics of advanced procedures like Lear for sidewall invasion, the critical mechanism of pelvic packing to halt venous hemorrhage, and the ingenuity of using a VRAM flap to fill the irradiated dead space of the empty pelvis.
It is arguably one of the most intellectually and technically demanding pathways in modern surgical oncology.
And it's worth stepping back to view this in its historical context. When Dr. Alexander Brunschwig first conceptualized and performed this operation in 1948, the medical establishment widely condemned it as too radical, too dangerous, and purely palliative.
Most of his peers thought the morbidity was completely unjustifiable.
Today, because of the evolution in imaging, critical care, and extended resection techniques we've discussed, specialized centers are achieving 5-year survival rates of up to 65% for a disease state that was once an immediate death sentence.
It perfectly illustrates the trajectory of surgical science. The absolute limits of yesterday become the standard operating procedures of tomorrow.
So as we close this deep dive, I want to leave you with a clinical scenario to test the core oncological principles we've covered today.
Let's hear it.
Imagine you are reviewing an MRI with the multidisciplinary team for a patient with a massive recurrent rectal tumor. The imaging shows the mass is densely adhered to the posterior wall of the bladder and encroaching on the presacral fascia. Based on the absolute mandate for survival in pelvic exenteration, what is the surgical imperative for managing that bladder, and what specific margin status must your team achieve to justify the immense physiological toll of the operation?
Consider the difference between anatomical preservation and oncological clearance.
If your conclusion is that the bladder must be taken en bloc to avoid peeling the tumor from fibrotic tissue, and that the team must definitively achieve an R0 resection, meaning microscopically clear margins of at least 1 millimeter, then you have grasped the fundamental mandate of advanced pelvic oncology. Keep analyzing the imaging, keep questioning the boundaries, and keep diving deep.